Our next speaker is well known in reputation, if not indeed in person, to many in this community gathered here. Michael Stubblefield is going to speak on the topic of living well beyond cancer, the role of comprehensive cancer rehabilitation in restoring function and quality of life to Hodgkin lymphoma survivors. Michael Stubblefield is the Medical Director for Cancer Rehabilitation at Kessler Institute for Rehab, National Medical Director for Select Medical's ReVital Cancer Rehabilitation Program, and National Medical Director for Complex Medical Rehabilitation for Select Medical's Inpatient Rehab Hospital Division. He's the former Chief of Cancer Rehab at Memorial Sloan Kettering. He's a clinical professor in the Department of Physical Medicine and Rehabilitation at the Rutgers, New Jersey Medical School, and he is board certified in physical medicine and rehabilitation, internal medicine, and electrodiagnostic medicine. His primary clinical expertise is in the identification, evaluation, and rehabilitation of neuromuscular, musculoskeletal pain, and functional disorders resulting from cancer and its treatment, particularly those caused by radiation and neurotoxic chemotherapy. We always look forward to hearing your thoughts and advice, and today we're eager to hear more from you, Michael Stubblefield.
You know, I was going to start with a joke about how happy I was that I wasn't following Aaron, but now I'm following Kevin. So, you know, just not right. So I'm sure there's an advancement button. Here we go. All right, so again, I'm a cancer rehab doc. So you can think of what I do in one of two ways. You can think of me as a sports medicine doctor for cancer patients, or more appropriately, a janitor cleaning up the complications of cancer and the treatment of cancer. And I don't do just radiation, I do everything. But I want to start with just what cancer rehabilitation is, then I'm going to tell you what's wrong with you, and then I'm going to talk about how to optimize it, if that's helpful. So it's a process, right? There's no one, boom, you're rehabilitated, you know, everything's good. But it helps you obtain, and this is important, the maximal possible physical, social, psychological, and vocational functioning within the limits created by cancer, and as you all know, the treatment of cancer, which is really one of the primary things for us. So being good at this requires a few things I learned early on. I have to understand cancer, but even more importantly, I have to understand the treatment of cancer. Kevin was talking about his nurse practitioner taking 10 hours to review a chart, and that is right. It takes a shocking amount of time. I torture my poor residents and fellows with how important getting all of those details in, because the devil is almost always in the treatment, or in the details. Then very importantly, all the comorbid conditions, those that you come to the table with, which might be your baseline osteoarthritis or cervical stenosis or cardiac issues, and then how all of those fit together, plus all your personal, psychosocial, those sorts of things. So the good thing is the principles of cancer rehabilitation, even for Hodgkin lymphoma survivors, are very similar to general rehab, but with the caveat, you really need to know all of these other things. So why do we need rehab? Well, because we're doing pretty good at our job, right? We're getting much better at treating patients. You guys all know we've talked about what a cancer survivor is, and I love the most comprehensive definition, meaning from the time diagnosis until end of life. I do inpatient rehabilitation. I don't do it myself, but I sculpt our practices, and sculpting rehabilitation plans of care for patients who are dying, for instance, is absolutely a valid and important rehabilitation endeavor, which we take very seriously at Kessler. So, and you guys, these data are a little bit old. I'm looking forward to getting the new slide from Emily, so thank you for that. Yours is much better than mine. You know, but there's a lot of cancer survivors, 18 million, rapidly escalating. Fortunately, the number of cancer deaths, about 600,000, and about 2 million cases a year. The problem is, while the vast majority of these patients have functional issues, and I can pace because I'm tethered, have functional issues, very few of them actually ever get rehabilitation. And this is kind of across cancer types, and I'll talk about the reasons for that and what we can do. Again, the causes of the impairments are manifold. I'll talk mostly about radiation in this talk, but as Kevin is world's expert in, the systemic therapies that we're using are also a tremendous source of impairment and debility in cancer survivors across the board. We were talking at lunch about the new biologic agents, right? Revolutionary. I've got friends with, metastatic melanoma that should have died a long time ago who are doing well out touring the world. In my case, bird watching, and it's because of these agents. That said, those of us who are in this field, have seen a lot of real tragedies from these biologic agents, and we really do not know the long-term effects yet. So what are some of the complications we see? So generally, when you talk to most doctors, they're going to say, you have pain. When you talk to me, I really want to get to the root cause of the pain. What exactly is causing your issue? And sometimes it's multiple, right? So when we're talking about neuromuscular things, could it be coming from your brain or your spinal cord or the nerve roots coming out of your spinal cord? The plexus, which is where they interconnect in like the shoulder girdle region and in the pelvis. The peripheral nerves, and there's multiple types. There are a number, right? I used to see breast cancer patients, when I first started at Sloan Kettering. So what would happen is Sloan Kettering had a fantastic pain and palliative and anesthesia pain service. So I'll just go back to breast cancer because this one's easy to understand. So you have a mastectomy, you have radiation, you come in with shoulder pain. You go to pain and palliative care, and I'm exaggerating a little bit. They start you on Tylenol and work you up to heroin, right? Because it's basically, right, oh, you're a cancer patient, you have pain, here, take 2 of these. Well, that didn't work. Try something, so pretty soon you're on like a fentanyl patch. So they would send the patient to me. I'm like, oh, you've got tendinitis and adhesive capsulitis. Let me give you an injection, put you on an inflammatory. And we did not have therapy, so let me send you outside to therapy. They come back great. I got very popular very quickly, right? Because not only did the pain and palliative care people who were fantastic, but really had that focus on patients at the end of the life, not really know the neuromusculoskeletal system. The oncologists were like, this is great, right? So we were able to rapidly expand the rehabilitation service because this approach was more in line with what people needed. And when it comes to Hodgkin survivors, I had no idea. There was no textbook. We now have a textbook. There was no papers on neuromusculoskeletal sequelae. My sort of superpower was that I was trained in internal medicine at Columbia, which was a very hard, very intensive care. So I dealt with a lot of sick patients. I knew a lot of cardiac medicine. I trained at Columbia, which was one of the best residencies for rehabilitation, right? With a lot of very sick multiple sclerosis and motor neuron disease. And I did a ton of EMG. The one you guys have probably had it. We stick needles in you and shock you with electricity for fun and profit. Yeah. So I love doing EMGs. And at Sloan Kettering, if I wanted to do an EMG, there was no pushback. If I wanted to spend 6 hours shocking you. And you know what's fun about the Hodgkin survivors? You guys would let me, which was hilarious because I needed that to really work out what your issues were. And it was that combination of medicine and knowing some neuromusculoskeletal stuff that allowed me to start sleuthing out what the root causes of the impairments were. So as you guys know, there's a huge spectrum, right? And I see this all the time from, somebody has thyroid cancer and they had a resection and there's not a whole lot to rehabilitate there. Sometimes they'll get a little cervical plexopathy, to Hodgkin's, head and neck, pelvic cancers, which are some of the worst where, you really have to have your game face on to understand. So to put you nobody's done this, and I'm going to assume a lot of you, even though you've had it, may not fully know Hodgkin's lymphoma and kind of how we got to where we are. So I just want to run through a couple things quick. One thing I think is really cool is that the first person to really describe the cure of Hodgkin's, limited stage Hodgkin's with radiation was Vera Peters, a woman back in 1950, which in and of itself is pretty interesting. Now, we've talked about the good cancer, right? So why was this a good cancer? Well, because if you had a non-Hodgkin's lymphoma, that's why there's Hodgkin's and then 1,000 other non-Hodgkin's types, at least that one was potentially curable, right? And again, there's nothing good about it, but that was why it kind of got that rubric. And then our treatments evolved considerably. Another little thing you need to kind of understand is the staging, right? And this is very important in this. So stage 1 would be like a little tumor. Very important to know where that initial tumor was because there's often, if you had a big right supraclavicular mass, that kind of helps explain why your right arm isn't working as well, right? Because there may have been some baseline damage from that tumor that was there, or they may have given you an extra boost of radiation. If you had it in 2 focuses, that'd be stage 2. If you had it above and below the diaphragm, 3. If it was out in the spleen or somewhere else, that would be stage 4. How would we know what stage you were back in the 1970s? Huh? Right, lymphangiogram, or better, we catch you open, right? Right, we didn't have CAT scanners. We didn't have MRIs. We had no way, we couldn't hold you up to the light and see what was going on. So we did all of these things that today are relatively barbaric to find out exactly where your cancer was, because that also helped us determine the treatment. So the treatment, largely, going back to Vera Peters in 1950, was what? Radiation. Barbaric radiation relative to what we do today, effective in treating the cancer, which is why we have a lot of people here, but also very effective in causing a lot of long-term issues. So the fields, and you guys all know this, mantle field would be basically everything, all the lymph nodes in the neck down to the diaphragm. They would shield the lungs, because if you didn't, they would turn into jello, and that's not compatible with life. But the shielding wasn't particularly good, right? If you had it below the diaphragm, you might have periaortic. If you had it down in the inguinal, ilioingual. If we did everything, that was total nodal. If you just had the abdomen here, it'd be, inverted Y radiation. So we had a number of names for the radiation, and you can see compliments of Dr. Walden, which I think I stole from Kevin some time ago in one of your slides. I apologize in advance, but that's such a good one, I can't let it go. And each tissue in your body has different tolerances to radiation. So this is an adaptation of another paper, but I put in an article I wrote sometime showing you, and let me just kind of calibrate this to you. So breast cancer radiation hovers around 50 gray and 25 treatments of 2 gray each. That's kind of standard breast cancer radiation. Sort of standard head and neck radiation is about 70 gray, also in roughly 30 fractions. Okay, just so you kind of know the numbers. We now have technology where we can give you single radiosurgery, 24 gray, like half of the breast cancer dose in one treatment to, say, a spine tumor, which causes a lot of issues. Right, so there's this sort of yin and yang of the total dose versus the side of the fractionation versus the tissue that is in the radiation field. You guys sort of with me? Okay, so, and I see how well my mic works because I want to come down here. So what we're looking at here is the total dose to cause 50% complications, whatever those are, at 5 years. What's our first problem here? Any 50-year survivors in the room? Right, so the first problem is the data does not even come close to capturing the people in this room, right? And that's a common issue with a lot of the radiation late effect studies that we see. But here, I said the lung turns into jello, it does. At 25 gray, half of the patients, and all of your lungs were probably included, at least in the periphery, in the radiation field, right? So a lot of people in here, I'm sure, have some degree of pulmonary fibrosis. As we start coming over here, right, bone is relatively radioresistant, joint and nerve is relatively radioresistant. So at 75 grays, the 5-year complication for nerve. Again, what's the problem? 5 years, right? That was decades ago for most of you. So you start getting nerve and other tissue complications depending what was included in the field. And remember, your fields were gigantic. We're now doing more involved field radiation, meaning because we have a nice PET scan, we can just do the mediastinum or just the supraclavicular lymph nodes. Still with high doses, right? But even though a lot of you only got 35 gray, 20 gray, some of you I've seen 42 gray, right? Everybody has different tolerances to it. So then a couple more definitions. One is radiation fibrosis. So radiation fibrosis is this hardening of the tissue, right? Sclerosis of the tissue that occurs in response to radiation, and every tissue gets damaged that is in the radiation field to varying degrees. Radiation fibrosis syndrome is all the crap that happens to you as a result of that tissue damage. Does that make sense? So they're 2 parts of the same thing. So what determines that? As I already said, this yin and yang. So total dose, but the size of the fractions, the other treatments that you got, right? So if you're a head and neck cancer patient, right, we did a neck dissection, that's not good for anything in your neck before we fry you with radiation. So you're gonna have potentially more issues there. You guys would have had splenectomies and laparotomies and all these all these other things. Not good for you, so that sets you up. The tissue, as we said, Protoplasm, what do I mean by that? Are you a healthy 15-year-old or a very sick 85-year-old, right? So that really determines how the patient does, and that's all those baseline characteristics I'm talking about, and then time. This is the gift that keeps on giving. The radiation left your body long ago, but it causes the tissue damage in this immortalized way, meaning it never stops. We can treat you symptomatically, but we have no way at this point in time of slowing down the radiation fibrosis that's occurring, if that makes sense. Okay. All right, so then it's about making predictions. One of my favorite quotes. I mean, it's just one of those truisms that we should all use often, right? And sorry, there's a little, I forgot to take out the chemo radiation. I modified this from another slide. But you guys all know this, right? You're born, you know, in your teens or your 20s often. You get the treatment. You might go through a terrible time of that treatment, right? And then things hopefully for a lot of people sort of leveled off. So this is kind of burden of impairments, right? And then at some point, a few years later, different for different people, and it's like this weird menu of some of you get cardiac disease, some of you get barrel reflex failure like Dr. Effinger, the blood pressure shooting up and down. Some of you get bad dropped head, some of you get plexopathy. No rhyme or reason to it that we know, right? But you know, it's this whole thing, so we've got to be on the lookout for all of these. One of the big things I talk about, and this was something that my time doing all these EMGs, and thank you, those of you who I've done EMGs on, right, allowed me to sort of sleuth out, and coupled with sort of a good neurological exam, is what was actually damaged. So what's damaged? Your spinal cord. So you actually get a subacute myelopathy. Myelopathy just means spinal cord damage, like you had multiple sclerosis or you were in a car accident, but this is a slow progressive thing. How do I know that? Clinical exam. Very commonly, you'll have brisk reflexes. I've seen detursor sphincter dyssynergia, which is this bladder issue, and a number of other things happen in Hodgkin survivors that really can only be explained by spinal cord damage, right, clinically. And, you know, at some point, hopefully we'll be able to, you know, do MRI tractography and sort of show it, but that just hasn't come up as a research project yet. Radiculopathy, what is it? My wife asked me, because, you know, she's a statistician into medical research. What's this radiculopathy you're always talking about? That is simply damage to the nerve roots, the radicals that come out of your spine. If you've ever seen a skeleton, they come like through the little holes. Commonly, when you get sciatica and you get a pinched nerve in your back, right, and you have pain radiating down the back of your leg, that's a type of radiculopathy. But in Hodgkin's, it can be a polyradiculopathy, and if you had or subtotal radiation or, you know, your lumbar spine, the lower nerve roots can also be affected. So those are damaged. What's the plexus? That's, again, those interconnections, right, inside your pelvis and your shoulders. Those could be damaged. The nerves coming off of that. So the spinal accessory nerve controls your trapezius and all the other things. And then the myopathy is the muscle weakness. And I could tell this by sticking needles in you, and nobody really described this, you know, just really weird, right? I get EMGs from other people, and I have to kind of laugh at them because they have no idea what they're looking at because they really didn't understand where you were radiated. And after torturing you poor guys for so long with these EMGs, I was actually able to start consistently mapping you out to kind of tell exactly what was damaged and where. Discovered a few things, like depending on if you had your arms down or up would tell me if the arms were going to be affected with myopathy or not, right? How many had your arms radiated down? How many had your arms radiated up, right? And a lot of you don't remember. Anyway, dropped head syndrome. See a lot of people with thin necks, protracted shoulders, head down here, who can't hold their head up, right? Super common. A lot of neck pain, neuromuscular dysfunction, sort of the neck's just not strong enough to hold you up. Then all these postural things, and that laparotomy or the sternotomy that you had for your cardiac disease doesn't help. All of that pulls you into this sort of C shape, right? Gait problems. See a lot of people walking around here, you know, who can't walk well. Again, that's another sort of neuromuscular degenerative thing. You might have your regular arthritis on top of it and spinal stenosis, meaning narrow of the spine, that's just degenerative, like dime a dozen thing in the world, but we see that. Fatigue, shortness of breath from cardiac and pulmonary function, cognitive dysfunction, depression, anxiety. That's just a short list, right? All right, so one of my favorite, a patient gave me this. And I think this was just so illustrative of what so many of you went through. And I was just so grateful when she allowed me to use these photos. But here we have a young woman, clearly probably in her 20s, right? And you can see it's staging laparotomy, right? Maybe took out the spleen. And you can see literally pretty gross, just marked her out with a red pen, right? To decide what the radiation field was going to be. And this is some radio-opaque block, right? That is literally what's going to shield the lungs, right? So this is in 1992, and here we are 23 years later. With all that obvious, as many of you have, neuromuscular dysfunction. You see just the wasting and the protraction of the shoulders are out to the side, right? The trouble lifting the head up. I'm sure a lot of you see yourselves in this picture. All right, so this is just a review of, at the time I had about 100 Hodgkin survivors at Kessler, and I was able to just have one of my residents do a chart review to go through and really just pull out what we'd said. We need to do this prospectively to be even more sort of robust in terms of what we're doing, and we're actually working on that. I have a postdoc now. So almost everybody had pain, 71%. About half had fatigue, about half had dyspnea, multifactorial for all of that. The neuromuscular issues, right, which I know you guys know, and anybody who's seen me at Kessler is in this study, thank you. But the myopathy or the myelopathy, the spinal cord dysfunction, I could see that clinically in over 80% of the patients. Radiculoplexopathy, hard to pull out, so I kind of lumped them together. Again, high, 93%. Mononeuropathies, damaged spinal accessory and other cranial nerves, 95%. Muscle, 93%. And then sexual dysfunction, underrated. I'm clearly not asking about it enough, right, to put it in there. And it's a source of embarrassment, but I put it out there to air to the world that we need to do better. Cognitive impairment, also not asking enough questions because I think it's probably much more common than that. Gait dysfunction, right, again, because that's something we concentrate on, pretty significant number. Dropped head syndrome, almost everybody. Now this is all a skewed view because if you're coming to see me, you've already got issues, right? It's very rare that somebody would come. So this isn't a picture of everybody. This is a picture of people who've come to see me from all over the world because they've seen me talking in forums like this, right? Neck pain, 80%, shoulder problems, very high. Dysphagia, swallowing. It's another big one that isn't talked about enough in this group and also contributes to the pulmonary dysfunction because if you're having swallowing issues, you're aspirating, we find this all the time, and you have a little subacute pneumonitis just from the fact that part of your food's going into your lungs periodically, and that doesn't help things. So I'm much more conscious of that now in patients who are coming in, and even trouble opening the mouth. Also probably too low, but fairly significant. Cardiac issues, again, these numbers are probably underestimating it. This is one thing we need to look at, but 70% of the patients, but multiple had several dysfunction. Valvular issues anyway. I won't torture you with all of this. Gastrointestinal dysfunction, very high, but we didn't specify what. All right, so now that explains what's wrong with many of you. Hope you don't mind. Again, I'm trying not to make anybody cry, if I can avoid it. But so what does comprehensive cancer rehabilitation look like? So this is one of my biggest things, and I'll talk about what I actually do for a living in terms of my cancer program in a minute. But I do not look at the world of rehabilitation in any way of being one clinician. This really takes a village. So I like the idea of having a cancer rehabilitation physician who knows, but I have an army of physical therapists, occupational therapists, speech language pathologists. I work closely with oncologists, survivorship clinicians, and anybody else, right, who we need to pull in to manage. This is very much all hands on deck to get the best outcome, but you always need a quarterback to kind of identify the issues and direct you to the right place. So again, the rehabilitation rates for cancer patients in general are very low. I'm going to guess that Hodgkin survivors, you probably seek it out more. Everybody in this room, I'm not even going to ask how many of you had rehab. I'm going to guess it's most of you because you're here, right? You're self-advocating at one point or another. So there's a few ways we do this, right? So one is, just a broad network coordinated by a physiatrist, me. One is oncology, that's the most common. And the other is like the Live Strong. I just wanted to talk about that briefly as you start, because I'm hoping to get out of this for you how to advocate yourself. What kind of model are you in? What kind of model do you want to be in? So this is my favorite model, right? Where I'm at the center of this little rehabilitation universe, right? Because I can control everything. Don't worry about me, I'll be all right. But I like knowing what's going on, right? And that doesn't mean I can't have Kevin and Emily over here, working on the medical side of it while I control the rehabilitation side. But once I get my hands onto somebody, I kind of own them in terms of the functional issues, because this isn't a love them and leave them situation. This is a long-term relationship because, again, the gift that keeps on giving. So patients are going to need to go back and forth to these modalities periodically, check on your home exercise program, identify, diagnose, and manage any new issues that come up, right? And just make sure that you're going where you need to go. Now, because I'm not associated with a major academic center, because most of my patients come in and do not have anybody who's really following them except maybe a primary care. I get into survivorship as well. I've learned from the best. So I'm constantly diagnosing and making sure cardiac, pulmonary, endocrine, renal, et cetera, issues. And this is something I'm really trying to roll out to the rest of my rehabilitation world, including my therapists, right? Because it makes no sense for us to just get this laser focus on the rehabilitation issues when the fact that you can't breathe is really the biggest functional issue. So we need to make sure that that is being taken care of. But this is the most common model, right? The most common model is that you have an oncologist or somebody who you've seen or have a relationship with, and they're the ones who's going to send you to places. The problem with this is their job is to kill cancer, right? So they really do not fully appreciate all of particularly the neuromusculoskeletal. They may be more versed. I see Kevin nodding, so that's good. I haven't insulted anybody. But they may be more versed on the medical side, right? So it's good to kind of have both. I see the pillars of survivorship really being the rehabilitation pillar, the medical pillar, and then the psychosocial pillar, right? But just know if you're in this, they may not be finding all of your issues that could be addressed through rehabilitation. And then kind of the worst is like the Livestrong model, right? And this is great if you had thyroid cancer or you had a stage 1 breast cancer and no real issues. But so many patients have significant sort of medical issues that really need to be addressed before we just throw you into the YMCA and an exercise program, right? And that's where we come in, right? Comprehensive rehabilitation means really diagnosing the full spectrum of issues that are affecting you and then treating them in a very coherent, systematic way. Another big thing that I'm a big fan of is what's called prospective surveillance. And we've been kind of dancing around this, but the idea is we know you're gonna have issues, right? So if you're a breast cancer survivor, a Hodgkin survivor, or you just had a prostatectomy, if you're a prostate cancer, there are predictable things, right? And we really need to be in front of them. We don't have a lot of evidence that staying in front of these things will make a huge difference, but we really believe it does. And certainly it kind of improves everybody's sort of, psychological well-being if you know that somebody's there to make sure that when you start developing an issue, we can diagnose and treat it optimally. So we're near the end here and I see the countdown going. I think after this, it just throws me off. So the rehabilitation, and I was thinking I'm gonna put in some core rehabilitation slides, but I'm not gonna do that. What I really want you to understand is that not all physical therapists are the same. If you need a heart valve, you don't go to the spine surgeon for it. They're both doctors, they're both surgeons, they know how to open and close you, but there is a huge difference in their knowledge, right? So one of the things that I'll talk about here in a minute I've done is to create a nationwide comprehensive cancer rehabilitation program called ReVital that has about 1,000 therapists operating in I think 25 states now. And every one of our therapists who've been trained will know radiation late effects. So they will have at least been taught it. They will actually be tested on it. They have to be certified and recertified. It takes 6 months to train a therapist who already may be a world-class physical therapist for sports medicine, but to learn the baseline just certification for cancer takes about 6 months. And then there's additional levels, right? They can become a specialist, that takes a year. They can become almost board level certified, which we call an educator, which takes like up to 2 years for them to be trained. So this is like the most robust comprehensive cancer rehabilitation training program in the country, but here's the catch. Just because they know it doesn't mean they practiced it, right? So even though they will know radiation late effects, that is very different from the guy who's done a Whipple when he was in residency versus the guy who does 100 Whipple procedures, which is a very morbid procedure a year. So the first lesson here is seek out a therapist or therapists, because it often takes multiple, who know cancer and know radiation late effects, right? But also ideally, and it's hard to get the ones who actually have some clinical experience, which I know is an impossibility in certain areas, but we're working on it, right? Why can't you find this? Well, knowledge, right? So you guys are all well educated. You've been here all day. You self-selected to come to this program. Almost all of you have seen Dr. Effinger, who educates extremely well. So you guys are very well educated, but your other doctors aren't, right? All of you who've been told this is in my head, you have fibromyalgia, it couldn't be the radiation, it was years ago, right? You're dealing with this sort of, you know, and they may be the best doctor in the world for everything else except radiation late effects. So education. Access. So even though we're building this program, it's not like it's easy, right? There's a reason it's never been done before, right? And there's a reason we're not in every state in the nation servicing everybody. That's the goal. But it takes time, and you know, there's financial and other barriers to try to getting it done. And then of course, getting patients to adhere to it. So I've got 4 seconds left, so I'm going to stop here. Just pointing out, you know, the ReVital program, these are the states where we currently are. We have bigger footprints in some than others. I'm very proud of the fact that we have programs in Alaska and Maine, right? I mean, just thinking about it, and we're growing kind of as we find partners and we can. So Select Medical, the company I work for, is about 50,000 employees. We've got really probably over 1,000 certified therapists, 500 clinics operating in 26 markets. I think that's slightly less states. So, all right. Oh, and I'm a bird photographer when I'm not playing doctor.